I'm Kelsey Schmitz, and I'm the Director of Training and TA at the UW Smart Center. We have a team of people on today helping to make this a great experience for everyone. We have some tech support on today. We have folks that will be posting links and resources in the chat. We are recording today, and everyone will be on mute and your videos will be off, but we will have the recording available in a couple of weeks. This project is being sponsored by a couple of different entities, the U.S. Department of Education's Institution of Education Sciences and the School Mental Health Supplement of the Northwest Mental Health Technology Transfer Center. On the next slide, we want to start with a land acknowledgement that the UW Smart Center and the Northwest MHTTC acknowledge that we learn, live, and work on the ancestral lands of the Coast Salish people who walked here before us and those who still walk here. We are grateful to aim to respectfully live and work on these lands with the Coast Salish and Native people who call this home. So just a quick little bit about the Smart Center. We are dually housed in the College of Education and the School of Medicine and the Department of Psychiatry and Behavioral Sciences. Our mission is to promote high quality, culturally responsive programs, practices, and policies to meet the full range of social, emotional, and behavioral needs of students in both general and special education contexts. And we do that through our training, our research, our technical assistance, and support to policymaking. And on our website, you can learn more about our research projects, our training projects, recent publications, faculty, staff, and affiliates, and our events, and much more. It has been quite some time since all of our Smart Center team has been in person together, but we do try to gather frequently virtually. So here is a recent photo, Zoom photo of some of our staff. And we're just also happy that you could join us, and we have many of our staff, faculty and staff on today. So just to give you a little bit of information about the way that we think about our work at the Smart Center, we focus on two primary gaps. The first, access and utilization, and the second is quality of services. There are major gaps, historical and inequitable, and even the most accessible service, if it isn't high quality, isn't going to be beneficial. A high quality service isn't going to be effective if there isn't broad access and utilization. So just to give you just a little bit more and go one step further on the next slide, you can see a little bit more about our role in setting the context through research, generating evidence by development and testing models that work, mobilizing that evidence through training and technical assistance, as well as learning more about implementation and TA strategies. And finally, through building political will by dissemination of information and being part of the conversations with funders and policymakers. One example of that is our UW Smart Policy Core. So I want to take just a moment on the next slide and introduce you to our UW Smart postdoc fellows, Dr. Corbin, Dr. Hugh, Dr. McVeigh, Dr. Zuloff-McCurdy. Part of the reason we are bringing you this series now for the fourth year in a row is through a grant from IES, which also allows us to bring these incredible postdocs to the UW Smart Center. And we're very thrilled today to have Dr. Corbin facilitating our Q&A later in the session. On the next slide, as I mentioned, the speaker series is also sponsored by our Northwest Mental Health Technology Transfer Center's School Mental Health Project, which is a part of a national network of mental health technology transfer centers. We know that many of you may be joining us from outside of our Region 10, and just want to make sure that you know which center to connect with in your area. I also want to bring your attention to two population focus centers, the National American Indian and Alaska Native MHTTC, and the National Hispanic and Latino MHTTC. You can visit the mhttcnetwork.org site to connect with other centers and to learn about center-wide activities. And then briefly on the next slide, this is our regional center, and we support the school mental health workforce in Alaska, Idaho, Oregon, and Washington, and we welcome you to connect with us. And before we pass it off to the most important part of our time together, this is just a disclaimer that while SAMHSA sponsors this work, it does not reflect any official position on this content. And now I would like to ask Dr. Arnold to join us. Dr. Arnold is a public health researcher and practitioner who addresses health disparities disproportionately experienced by Black Americans and engages in multi-sector collaboration to address inequities and social determinants of health in the areas of food security, housing, education, and mental health care access and quality. Dr. Arnold is a leader in health equity, community-engaged research approaches, and implementation sciences. She conducts research in partnership with community members, practitioners, and policymakers to increase and improve the adoption, implementation, and sustainability of evidence-based mental health interventions in community settings with a focus on schools and churches. Dr. Arnold earned a BA in biology with minors in African American Studies and Health from the College of Charleston in 2012, MPH from Drexel University's Dornsiff School of Public Health and Human Rights in 2014, and a PhD in Health Policy and Management and certificate in Community-Based Public Health from the Johns Hopkins Bloomberg School of Public Health in 2019. And in 2021, she completed a National Institute of Mental Health T32 postdoc fellowship in implementation science, mental health services, research, and academic community partnerships at the Penn Center for Mental Health, and is currently an assistant professor of family medicine and community health at the University of Pennsylvania Perelman School of Medicine. And we are so honored to have you join us today and want to hand this off to you for the rest of our time together.
Thank you so much, Kelsey. I really appreciate that warm introduction. And I would like to say thank you as well to the SMART Center, the University of Washington overall, as well as the MHTTC. I really appreciate this opportunity to share strategies for advancing mental health equity in schools. So I'll just go ahead and jump right in. And I'm gonna start with a personal story. So when I grew up, I actually grew up in South Carolina in a really small rural town. The population was about 100,000. And during that time, mental health was highly stigmatized. And it was somewhat taboo to openly discuss mental health, whether within the household, outside of the household, at church, at school. It just wasn't discussed when I was growing up. There were no preventive mental health interventions at my school, and only students who were in special education received any type of services at my school. When I was in 7th grade, one of my friends attempted suicide, and there were no services available to help her at my school, and she was sent to a residential facility for treatment. 10 years later, when I was in my master's in public health program, my nephew's friend, who was attending the same middle school at the time, ended up actually committing suicide, and there still were no school mental health programs available within my school district. And so when I was in my master's in public health program, I really started to develop an interest in mental health and trauma, specifically when I was taking a course in trauma and public health. As a part of my community-based master's project, I interviewed mothers of young children who had reported household food insecurity, because that was an area that I was really interested in at the time. And I was working on a study that was looking at the relationship between childhood adversity and food insecurity as an adult. When I was interviewing mothers, it was a group of Black and Latina mothers in Philadelphia. I started to notice patterns when I was interviewing the mothers, as well as when I was analyzing the interview transcripts after the interviews. And I noticed that women who had received some type of mental health support when they were in school were more likely to complete high school, compared with other mothers in our sample who had reported not receiving any type of mental health support when they were in school, and had then gone on to either not finish high school or to maybe finish later down the road, but they didn't. Overall, the pattern was that they didn't graduate from high school. and we're dealing with trauma, symptoms of trauma, dealing with trauma-related conditions such as anxiety, depression, PTSD. So during that time, I really wanted to find out more information about how schools can potentially be a place of support for children who are experiencing childhood adversity, whether that's within the home, outside of the home, in their neighborhood, in the school. And so when I entered my PhD program, I had the opportunity to apply for a training grant program that was focused on mental health systems and services. And I knew right away when I entered into the program that I wanted to focus on schools. And as part of that process, I started to visit different schools. I also worked with a program that was really focused on delivering trauma-informed care to adolescents in middle schools, which I'll talk about later in this presentation. But overall, I really noticed that within Baltimore City, there were a lot of resources for mental health compared to the small rural town that I grew up in. So there were resources such as nonprofit community organizations that were focused on mental health and partnered with schools to deliver services. There were also universities such as Johns Hopkins University, where I was a student, as well as the University of Maryland that had the National Center for School Mental Health. So there were a ton of resources when it came to universities to partner with or community organizations. And then there were also foundations who were offering funding for mental health services on top of other sources of funding through federal sources, state funding, and local funding. In addition to all of that, there was also an actual mental health policy at the local district level in which mental health was included within the blueprint for city schools. And it really encouraged schools to adopt and implement school mental health interventions across various tiers to support students and to not only improve their mental health outcomes, but to also improve their academic outcomes as well. So all of those experiences informed my interest in advancing school mental health equity. And so today I'm going to share with you these objectives, and we're going to go into depth into some things, but of course we don't have a lot of time to go into depth into everything. But overall, my objectives are to explain the burden of mental health challenges among children and adolescents and associated disparities in school mental health care, state the importance of involving stakeholders in the development, selection, adaptation, implementation, and evaluation of interventions, as well as discussing examples of policies, interventions, and implementation strategies to advance mental health equity in schools. And then last, I will end with a tool that you all can use in your work to adapt implementation strategies to advance equity. So first, I'm going to start off with just sharing a few statistics on children's mental health and school mental health disparities. So overall, approximately 1 in 6 children between the ages of 6 and 17 has a treatable mental health disorder. Approximately 80% of children and adolescents with mental health diagnoses have unmet mental health needs. So obviously there's a huge gap there. That's an area where we are seeking to work in order to advance equity and to get children and adolescents the help that they need to support their mental health. ADHD, behavior problems, anxiety, and depression are the most commonly diagnosed mental health disorders in children. And approximately 9% of children between the ages of 2 and 17 have received an ADHD diagnosis. Approximately 7% or 4.5 million have a diagnosed behavior problem. About 4.4 million have diagnosed anxiety, and then about 1.9 million have diagnosed depression. And these are stats for actual diagnoses. So the numbers could be higher because of the fact that universal screening is not done everywhere. So there may be some children and adolescents who are flying under the radar. Diagnoses of depression and anxiety are more common with increased age, as you can see here. And overall, the rates of mental disorders among children vary with age. Behavior problems are more common among younger children around the elementary school age than older children or younger children who are in that early childhood education phase. Children's mental health disparities exist by sex, socioeconomic status, and race and ethnicity. So overall, these are just some high-level stats. So among children aged 2 through 8, boys were more likely than girls to have a diagnosed condition. And then among children living below the poverty level, more than 1 in 5 had a diagnosed mental, behavioral, or developmental disorder, which is higher than that overall general rate that I mentioned earlier. And then children of color and children living below the poverty level are more likely to be exposed to trauma. So children of color are disproportionately exposed to trauma and are less likely to have access to mental health services. So on the left are just some of the examples of various exposures to trauma. Of course, COVID-19 is in there, food insecurity, neighborhood violence, racism. And then on the right side are various types of mental health supports that they are less likely to receive. And so that includes support at the individual level, such as individual counseling, as well as group therapy, family therapy, in addition to evidence-based mental health interventions, which are typically delivered in schools, sometimes delivered within community settings as well, such as churches or homes or community recreation centers and things of that nature. But the main point here is that these gaps exist, and these are areas that we are hoping to address and to improve for sure over the next several years. And then COVID-19 has had an increased effect on mental health of children and has really increased mental health problems among children between the ages of 2 and 18. And as you can see here, overall, 6 in 10 parents reported that their child has experienced mental or emotional health challenges within the past month during the time that this survey was administered in 2020. And this was most likely due to social isolation or loneliness, anxiety, and trouble concentrating. And so during that time, that's when a lot of schools were shut down. Kids were at home. Some of them didn't have siblings to be at home with them. Some of them were missing their friends because they weren't able to go to school. So there are a whole host of issues there. And of course, it was difficult for them to transition to virtual learning. And in some areas, like my hometown, a lot of kids did not even have access to broadband internet. And so there were a lot of issues around not even being able to really engage virtually because of those internet issues. And then when we look at rates among teens, it's very similar. And parents had also reported that about half of teens have experienced mental or emotional health challenges within the past month. And most commonly, the issues were anxiety, trouble concentrating, social isolation, and loneliness. So it's very similar to the younger children. And parents were most likely to say that it's extremely essential and important for schools to address these issues. And when we really look at how COVID-19 has exacerbated mental health problems among children and adolescents, we see that 3 in 10 parents reported that their child's emotional or mental health has been worse since the onset of the pandemic, compared to about 53% who said that it's about the same. And so this could also indicate that some of their children were already having mental health challenges prior to the pandemic, and now many children are experiencing worse symptoms, and some children who weren't having issues before are now experiencing mental health issues. And parents, again, within this study had really mentioned that it's important for schools to help students with these challenges and to provide services to help their students cope and to help their children cope with the pandemic, to also cope with that transition back to school, to also cope with just all of the changes that have occurred. Many children experienced loss during the pandemic, whether that was family members passing away, maybe friends, people that they know in their community. So there has been a lot of grief and a lot of loss during this pandemic, in addition to just things that they missed out on, of not being able to go to their prom or to go to their graduation or to really celebrate their birthdays in the way that they may have wanted to celebrate. So there's just been a lot that has happened over the course of these past 2 years. And as we enter into this third year with a lot of schools being back in session, we know that things are not completely back to normal yet. And so although on the parent side, they're really wanting a lot of these issues to be addressed, on the school side, some schools are able to provide that support, and then other schools are still struggling to figure out how they can best support the mental health of their students, as well as the teachers and other staff who are doing the best that they can to help children during this time. On the positive side of things, though, schools do have that potential to increase children's access to mental health services. And prior to the services being disrupted by COVID-19, schools were really, doing what they could at all of these different levels that are pictured here on the screen to address mental health challenges, as well as to prevent the onset of mental health disorders among children in schools. And the good thing about it is that children spend most of their time in schools. So offering mental health services in schools is a great way to increase their access to services. And when we've looked at some studies, they have demonstrated that some children only receive mental health services in school, and they're not receiving it in specialty mental health settings in the community or in other areas. And so schools really play a huge role in being able to provide services to children who would otherwise not be able to receive services. And then schools can also provide a multi-tiered system of support for mental health, which I'll talk more about later in the presentation. But as you can see at the tier 1 level, creating a safe environment and promoting healthy and successful students is something that can be done and that would benefit all students, regardless of whether or not they have a diagnosed condition. So some of the key interventions and strategies that are used at this level include promoting positive school climate, psychological first aid, bullying prevention programs, positive behavior and intervention and supports is also is PBIS, which many of you may have heard of before, is also at that tier 1 level, and they also provide services at the other levels. And then also just providing general wellness support and education is really helpful for just educating students about mental health, talking to them about signs that they may notice within themselves or within friends, and then just providing them with other types of complementary wellness support, such as physical activity, healthy eating, which also help to support mental health. And then at that tier 2 level, this is really focusing on early intervention and identifying students and staff who are at risk. And this is another area where schools really shine, because otherwise some of the kids would not be screened at all, and they would go on to grow up without having a diagnosed disorder or getting the help that they need, which can lead to adverse health effects in adulthood, as well as adverse socioeconomic outcomes as well. And so it's really important to screen students when possible, and to also offer group interventions to support students who are at higher risk. So offering group interventions such as cognitive behavioral therapy, which could also be offered individually, but there are some CBT interventions that are designed specifically for schools, such as the cognitive behavioral intervention for trauma in schools, which really focuses on addressing trauma, really helping kids who have been exposed to trauma, and to prevent the onset of PTSD. And if they already have PTSD, it can help to reduce symptoms. And then also offering various forms of peer support. And then at the tier 3 level, this is really focused specifically on interventions for children and adolescents who have a diagnosed condition. And so at this level, this may include things like medication management within the schools. It may include individual therapy in schools or family therapy within the home, and then also trauma-specific treatments. So again, with CBITS, that can also be used at that tier 3 level for children or adolescents who have been diagnosed with PTSD. And then one key thing I want to point out here too, that I'll talk a little bit more about later, is that partnerships are extremely important. So I just want you to keep that in mind as we go throughout this presentation of how important it is to really develop partnerships within and outside of the school to really advance school mental health equity. So when we really think about school mental health disparities, a lot of schools in marginalized communities often encounter significant barriers to offering interventions across the tiers that you just saw on the last slide. And many of them have limited access to and the capacity to implement evidence-based interventions. And then on top of that, not all schools have mental health interventions. So when we think about the differences between rural and urban schools in different geographic locations within the US, and then also thinking about schools who are well-resourced and have funding, have staff, have these different facilitators that can actually support implementation versus schools that are under-resourced and may have limited staff, may not have funding for these interventions. Maybe they have time constraints within their schedule where they're trying to fit in things related to curriculum because of the fact that they're held to these high standards for testing, and just don't think that they would be able to integrate mental health interventions into their curriculum. There are all different types of issues that we've seen with schools. And so at the end of the day, not all schools even have school mental health interventions. And then not all children in schools who are in need receive mental health services. So even within schools where there are mental health services available at the various tiers or a combination of those tiers, not all children who need services receive services. And this is again kind of going back to the issues around screening and how screening is not universally done because of the fact that some of the schools don't have the resources to then provide assistance to the students within the school, or the capacity to refer them out because maybe in that area they don't have services outside of the schools where children can go. So we see all of these different types of situations. And then also evidence-based interventions for mental health are not being widely implemented and sustained. Sometimes they are implemented maybe as part of a research study or implemented as part of a pilot or just a trial basis, or maybe it's implemented as part of under the leadership of one principal, but then when that leadership changes, maybe the intervention goes away. So we are seeing that there are issues around sustainability as well. And then of course, there's a shortage of school mental health professionals to provide services. So in some cases, we can train lay staff members to deliver interventions, but in some cases, school mental health professionals are needed for things such as screening in some cases, for delivering certain types of intensive supports. And so this is an area as well where we are hoping to see changes within the mental health workforce within the next few years. So now I'm going to talk a little bit about engaging stakeholders in school mental health interventions. And this is an area that I'm really passionate about because nothing happens in a vacuum. And so when we're delivering school mental health interventions, there are different people who are involved, whether they are receiving the interventions, such as students, And sometimes teachers and staff may be receiving certain types of interventions that are focused on promoting their well-being. Then parents and families are also involved because of the fact that in many cases, parents have to give permission for their children to receive services at school. So they are definitely a part of the picture as well. In addition to school mental health professionals who may be implementing interventions, conducting screenings, referring students to services outside of the schools. They may be engaging with other mental health professionals outside of the school context. And they may or may not be integrated within the school, which could also influence implementation. So in some cases, the school mental health professionals are hired to be part of that school. They're integrated within the school. They are, responding and answering to the principal of that school. And then in some cases where we have co-location of mental health clinicians who are working full-time for a community mental health agency, but delivering some services in schools, they most of the time answer to their clinical administrator at their agency, and not necessarily directly to the principal in the same way that a clinician who is embedded within the school is seen as part of that school's fabric. And so these are also areas in which we have seen differences in implementation of interventions when mental health professionals are actually embedded in the school, and then when they are not embedded. And there are different strategies that can be used to integrate them more into the school so that they are seen as part of the school and that we're all in this together to provide services to children and to improve their mental health outcomes. And then, of course, school leadership is really important. The principal, a lot of the times, is the one making the decision to adopt new interventions. They make the decision to sustain interventions. And a lot of times they also have the power to integrate mental health interventions into the budget for the school year, or to be active in establishing partnerships with local community mental health agencies or local organizations who can help to support implementation of interventions. So when we think about school mental health, we have to think about all of the various stakeholders who are involved and ensure that we are involving them, because it has so many benefits for implementation of interventions, but also the other things that you see pictured here on the screen. So it demonstrates respect first and foremost, because you're acknowledging that these stakeholders are part of the picture and that they have a role within the broader scheme of delivering mental health services to children. And then it also builds trust, especially when it comes to parents, and really building that trust with them to know that as a school mental health provider, or as a teacher, or as a principal, whoever you are within that school space, that your goal is to promote academic outcomes, to improve academic outcomes of the children, to improve their mental health, and that you're all working together as a team with the parents, and you want to understand where they are coming from when they may have concerns about enrolling their child in a mental health intervention because of stigma or because of other reasons. Is really helpful to involve them in that process of selecting interventions for the school, involving them in the adaptation process, also keeping them updated as implementation occurs so that they know what's going on and that they feel that they're a part of what's going on and that they know what's happening with their child in school. And then it also improves selection of implementation strategies that we're using to try to figure out how can we improve implementation, how can we get more schools to adopt these interventions, how can we convince more parents to sign their kids up for certain interventions. So involving these stakeholders in that selection process can really be helpful in selecting the strategies that will be best for that particular intervention, for that particular school, or for a particular student population who will be receiving the intervention. And then, of course, outcomes are important because we want to be able to have beneficial outcomes when it comes to implementation outcomes, clinical outcomes, because those together will improve the overall outcomes for children as it relates to their academics as well as their overall well-being. And so when you involve stakeholders in that implementation process, there are plenty of studies out there that document that this improves acceptability of these interventions. It improves the feasibility of offering those interventions within that school or within similar schools. It also improves fidelity of the intervention and ensuring that the implementers are implementing the intervention as intended, as well as improving the appropriateness of the intervention for that particular school, as well as the population who will be receiving it, whether it's students, teachers, staff, whoever is receiving the intervention within that school context. And then last but not least, when it comes to evaluation, it's really important to involve stakeholders because of the fact that you can get different perspectives on the implementation efforts and outcomes. So when I was doing my dissertation research on factors that influence sustainability and adoption of a trauma-informed universal mental health intervention, I interviewed different stakeholders, such as principals, teachers, school mental health personnel, to kind of get a sense of what are their views on how the implementation of the intervention went. What outcomes are they already seeing anecdotally while we're still in the process of trying to analyze data. And we know that when you're analyzing data for a large trial, sometimes that can take time. So it's really helpful to engage in that qualitative work of doing interviews, doing focus groups, and really learning directly from those who were directly involved or who received the intervention on how they think that things went. And that will help to then improve the next iteration of the intervention when it's implemented. So now I'm going to talk a little bit about just different strategies for advancing school mental health equity. So mental health equity can be advanced within and across all of these different levels. So at the policy level, there are things that can be done to advance equity within schools and within school districts as a whole. And then at the community level, again, going back to the partnership piece of partnering with community organizations that can support implementation or that can provide funding or that can provide additional support or staff, all of that can be really important. So it's always good to look at the broader community and not to just stay focused on the school itself, but how can you leverage assets that are already available at the community level to enhance implementation of the intervention that you are delivering or of the services that you're providing. And then at the school level, there are also things that can be done to really promote equity, to reach more children, to assess the outcomes of the different efforts that are being done, and then to also involve more of the stakeholders within the school to, again, enhance implementation and to improve outcomes. And then at the intervention level itself, there are also things that can be done to really maintain the core elements of the intervention that make it successful, but then to also maybe make some adaptations so they can be a better fit for the school. And then also using implementation strategies to enhance implementation, which I'll talk about a little bit later. So first, starting out, I just want to give some examples of policy solutions. So leveraging funding is really huge. And that's one of the great things about policy, that it can provide funding. It's great that we have these different agencies that provide funding in the form of grants and various support to school districts and to individual schools. And so I've listed some of those agencies here. And then also COVID-19 recovery funds can also be used to advance mental health within schools and to maybe start offering some interventions that weren't offered before due to funding issues. A lot of districts, a lot of states are getting millions of dollars in funding. So it's really good to try to leverage some of that funding to support your mental health efforts. And of course, to always try to take advantage of state Medicaid funding, because that definitely has different requirements in there for taking care of the mental health of children. And so really being able to leverage some of that funding is helpful for school mental health interventions and services. And then developing local policy at the district level can also promote implementation as well as funding of school mental health services. And when the district is on board with mental health, and when they are constantly hosting professional development sessions or offering support directly to principals in the form of resources or seminars or workshops, that really helps to drive home the point that mental health is important and that it is something that should be addressed in schools. And it also helps to promote best practices within districts so that schools can come together and share what they're doing in their school that has been successful, and really talk through some of the barriers that they may be facing. And then to know that since it is a priority at the district level, it's not something that they have to feel that they're doing in secret or that they're doing behind the back per se of the district administration. And it is just something that really helps them to feel as though they are part of a broader mission to really improve the mental health outcomes of students within the district. And this is just some examples of how various states are addressing mental health and how they are leveraging different resources to improve mental health of students. And so we can see that, like even for instance, in Maryland, Project Bounce Back, which is it's kind of like a version of CBITS for younger kids, where it's really trauma focused. It really helps kids to cope with trauma, and they're able to leverage some of the COVID-19 recovery funds for this, and then to also expand Boys and Girls Clubs to every county in Maryland, because that is something that is also really important when it comes to supporting mental health, is having recreational centers where kids can go to get peer support, where they can receive mentoring. And then we also see that in other areas, they're focusing more on behavioral health promotion, prevention, and intervention services. So really trying to improve their delivery of interventions across the different tiers to really focus on improving outcomes among kids. And then some places such as the Atlanta Public Schools are planning to increase screening so that they can really have a better sense of what's going on with kids in their districts, and so they can then provide adequate support for those children, and then to also train staff in trauma-informed practices. And that is something that we are seeing more often now, of a lot of schools and a lot of districts really focusing on increasing prevention programs for trauma, increasing social and emotional learning, and really increasing mental health awareness overall, because of a lot of the issues that we've been seeing with the increases in rates of mental health issues among kids, increases in suicide ideation, and suicide attempts. So all of this is really important to just kind of see these different examples so that we can see how different places are leveraging funding to promote mental health and to advance equity in their area. So at the community level, again, going back to partnerships that I mentioned would be very, very important throughout this presentation. Partnering with local community mental health agencies, community groups and organizations such as the Boys and Girls Club, YMCA, Big Brothers and Big Sisters of America, as well as faith-based organizations, is really important to really promote health equity and to promote mental health equity among children. And it really provides the opportunity for kids to receive support at school, but then to also be able to go home and go to their community to receive complementary support as well. And then also, in some cases, staff members or mentors from these different groups can come into the school to serve as as a staff member for a mental health intervention where lay staff members of the school are delivering interventions and maybe looking for support. And that was one of the things that we did with the intervention that I had mentioned earlier that I helped to deliver when I was in Baltimore, in which a young adult community mentor was paired with a school staff member to deliver the intervention. And that really helped students to feel more comfortable, for them to also see someone who's older, who looks like them, who may have gone through similar struggles as them, or maybe going through similar situations within their community or within their home, and can help to destigmatize talking about mental health and addressing mental health concerns. And so partnerships are really key when it comes to looking at those community assets. And then when it comes to community mental health agencies, in many cases, those agencies can leverage that Medicaid funding that I mentioned earlier, and they can come into the schools to provide services and to really work with schools to figure out what gaps are there so that those gaps can be filled. And then to also figure out how to evaluate existing services and how to improve those services. And then at the school level, there are different solutions, such as establishing multi-tiered systems of support for mental health, implementing evidence-based interventions across those different levels, implementing more trauma-informed and more universal interventions, which we are seeing that more now because of the pandemic, and realizing that all kids can benefit from universal interventions. And because of the fact that COVID-19 has been a traumatic experience for everyone in one way or another, really embedding those trauma-informed programs in schools is extremely important, not only for the students, but for teachers as well, who are stressed, who are trying to teach in person. They've been teaching online or doing a hybrid, and many teachers are burned out, and they also need support. So really being able to provide interventions for the entire school, to really acknowledge the fact that we're all struggling during this time and we can all benefit from support. And then integrating mental health care within school-based health centers. So this is already done in some areas, but in other areas where it may not be done yet, this is another area where those COVID relief funds can come in to establish the integration of mental health care within those school-based health centers, integrating screening and treatment for the mental and physical conditions, and providing kids with the help that they need within those school-based health centers. And then also creating comprehensive school mental health systems, which goes back to the community again, and which are going beyond just providing the multi-tiered systems of support for mental health within schools. It also includes the community and community support, and really builds upon the assets within communities and the assets within schools to provide a continuum of mental health services for students at all three levels, whether that's the universal level, tier 1, or the tier 2, or the tier 3 intensive level, and really being able to also provide wraparound services in many cases for kids who are also in need of social services in addition to mental health services. So now I'm going to just give a little bit of information about Project Power, which is an intervention that was really focusing on promoting options for wellness and emotion regulation in Baltimore City schools. So one of the components was a general health education program that was just focused on general wellness topics. And then the intervention that I worked with was a RAP Club, which is a trauma-informed mental health intervention. And so in all of the schools in which Project Power was delivered, all schools received both RAP Club and Healthy Topics, and students were randomized to participate in either one. But eventually the goal would be for us to deliver this as a package so that we can have a holistic approach to mental health, and that kids are learning about overall wellness in addition to ways that they can support their mental health, and then also learning that link between mental and physical health. And so Project Power was delivered to over 800 eighth graders within 29 schools through 2016 through 2019. So the last cohort finished literally like right before COVID started. So Rap Club was designed for adolescents living in low-income urban areas, and it was adapted from psychotherapy, structured psychotherapy for adolescents responding to chronic stress called Sparks. And so this intervention was really designed to focus on prevention of potential negative effects of chronic stress and trauma exposure. And it's a 12-session group-based program that can be delivered by a lay school staff member or a mental health clinician along with a young adult community member. So when we look at the core components of Rap Club, it's firmly rooted within evidence-based practices. So that includes psychoeducation, and within the intervention, it really talks with students about how they can identify stress, the different signs of stress, how it shows up in the body, how it can impact their emotions. Mindfulness is also a huge component, and that really focused in the intervention on using a mindful approach to dealing with situations that come up in everyday life, as well as being aware of the various emotional states that we have throughout the day and how that may change if we're experiencing a traumatic situation or a very highly stressful situation. And then also incorporating CBT skills for communication, problem solving, distress tolerance. And then mindfulness was also used for some of the distress tolerance skills as well. And so together, this intervention really helps students to address trauma if they had experienced trauma. And for students who hadn't experienced trauma, it was helpful for them to gain these different tools so that if something comes up down the road, they would have these tools in their toolbox to respond. And then to also just in general, because this was delivered to eighth graders, there are also components in there that help them to manage that transition to high school and to prepare for that transition. Manage that transition from middle school, from eighth grade going into ninth grade. So when we look at how Rap Club was adapted, this is a perfect example of how stakeholders can be involved in the selection of an intervention, how they can be involved in the adaptation of an intervention, as well as how they can also be involved in the implementation after this process has been done. So just to give a really brief overview of how Rap Club was adapted, it started with academic researchers building a partnership with a local nonprofit community-based organization that was co-founded and led by Black community members. So this occurred in Baltimore City, which is a predominantly Black city. And the researchers, some of them were Black, some of them were not. But the thing is, when you are an academic researcher, even if you look like the community, sometimes you are still seen as an outsider because you are part of a university. So it's still important to take time to build trust, to build a relationship with community partners so that you can really have a good understanding of who they are, what their interests are, what their priorities are, and then to also share from the academic side of these are best practices that we've seen, these are our best practices that we recommend, and how can we come together to work together to deliver an intervention that's going to serve the needs of the community, but is not going to be deficit focused, but will also build upon existing assets within the community. And so after building a relationship and a partnership with the local community organization members, a community advisory board was formed that consisted of members from the community, local universities, as well as the local health department. Afterwards, the community advisory board worked together to identify unmet mental health needs among local Black adolescents and young adults. So it wasn't a situation where they were just coming in and saying, we have all the answers, we know what the problems are. They actually took the time to work together to figure out what the unmet mental health needs were, and to talk through it together. On the community side, what do you think? What do you see? From the researcher side, what do you see? From the health department side, what do you see? And really coming together to figure out what the main needs are. And then from there, the researchers selected SPARKs based on the mental health priorities that were identified by the Community Advisory Board. And then the Community Advisory Board reviewed the curriculum and confirmed that it was appropriate for the population of Black adolescents in the area. And then Black young adults from the community were hired as consultants to assist with adaptation of SPARKs along with the researchers and the Community Advisory Board. So in some situations, researchers may solicit help from community members without paying them. And it really is a best practice to pay people for their time and their expertise because they are experts as well. So it's really important when we're in these situations where we're making adaptations or making changes to interventions or services, to pay people when possible for their time and expertise. And then after that, the researchers adapted SPARKs to be delivered in schools because initially SPARKs was a group intervention that was not necessarily designed for schools. So they adapted it to be delivered within schools. And then last, Black young adults helped to implement the intervention within predominantly Black Baltimore City public schools during the pilot phase, as well as during the actual Project Power trial. So overall, building partnerships, forming a community advisory board, promoting adaptability of evidence-based interventions, and engaging intended intervention recipients in implementation efforts are all considered to be implementation strategies for enhancing implementation as well as sustainability of school mental health interventions and promoting mental health equity overall. In this particular case, careful attention was given to building partnerships and forming that community advisory board that consisted of various stakeholders that included young adults as well as Black adolescents. And then together, there was active participation throughout the adaptation phase as well as during implementation of the actual trial. And so speaking of implementation strategies, now I'm going to talk a little bit about some specific implementation strategies that can be used to advance equity within school mental health. So just to make sure everyone is on the same page, when I'm saying implementation strategies, it means methods or techniques that are used to enhance the adoption, implementation, and sustainability of a program or a practice. And so there is I put a citation here for a full compilation of these strategies because there are about 73 strategies overall. So of course we don't have the time to talk about all of those strategies right now. So we're going to, so I'm just going to pull out some of the strategies that are really focused on, or that can be used to promote equity within schools. And so overall, there are about 9 categories of the implementation strategies. And so these strategies can be used to address disparities and to promote equity overall. And so when we look at the first category of using evaluative and iterative strategies, 2 strategies that I pulled out that can be really useful for promoting equity are assessing for readiness and identifying barriers and facilitators, as well as obtaining and using student feedback. So when we look at assessing readiness, so this can look different ways. So you can do things such as conducting a needs assessment at the beginning to kind of see like what the needs are. And then when it comes to actual readiness to implement the intervention, you can also work with school stakeholders to really figure out, are they ready to implement the intervention? Do they have adequate support? Are there things that are needed? Are there things that need to be done prior to implementation to ensure their readiness? And then also in thinking about the various aspects of the school context that may determine whether or not the school personnel are ready to implement the intervention, and also thinking about any barriers that may already be present that may impede implementation, as well as thinking about the strengths or the facilitators, such as staff members who can help to deliver the intervention. And then also thinking about how various facilitators and assets can be leveraged to really enhance the implementation of the intervention. And then when we think about obtaining and using student and family feedback, again, this goes back to the involvement of stakeholders. And really, because of the fact that students are a lot of times receiving these interventions and families or parents may have to sign off, it's really helpful to get their feedback on how implementation is going, getting their feedback on what their main priorities are as it relates to mental health, and then also answering any questions and just being transparent in that process, and then making changes as needed. And then for providing interactive assistance, so this kind of comes down to, there are other things within this category, but technical assistance is really key. And a lot of times, especially when schools may be implementing new interventions, having some technical assistance can be really helpful in helping them to deliver it with fidelity, but then to also address any barriers or any issues that may come up along the way. And so when we think about a centralized system, that can be within a district, a region, or within a state, that can help to facilitate access to technical assistance that's really focused on any implementation issues that are coming up. And then if you're not able to really centralize it, providing local technical assistance with school personnel can be helpful as well, to provide technical assistance within the school for interventions that are being delivered there. And then when we look at adapting and tailoring the intervention, promoting adaptability is one of my favorite strategies, because I just like to be flexible. And as long as you are maintaining the core elements of the intervention, it's okay to adapt it to better fit the school, to better fit the population that is intended to receive the intervention. And I'll go into a little bit more depth in an example on that later. But it's really important to think about the ways that the intervention or the practice could be tailored or adapted to best fit within the classroom, if it's a classroom-based intervention, or within the broader school context. And then also making sure that it's meeting local needs. And then again, going back to those core elements, is really important to clarify which of those elements have to be maintained in order to preserve the integrity of the intervention. And then when we think about tailoring strategies, sometimes there may be ways that you can just slightly tailor the strategy and maybe change something to better address a barrier that was identified early on when you assess for readiness and identify barriers and facilitators. And so sometimes strategies can be slightly tailored to better fit the setting, or to better address a certain barrier that may have been identified, or to leverage an existing facilitator within the school. And then when it comes to developing stakeholder interrelationships, again, partnerships. I cannot stress that enough during this presentation. It's very important to build partnerships within the school. So that could look like the leadership of the school ensuring that they're communicating regularly with the school mental health team, having those team meetings where you have leadership present, you have school mental health personnel present, you have representation from teachers present, you have representation from families present, to really talk through what is needed, what's being done, what needs to be done, and what changes need to be made along the way. And then also organizing those implementation team meetings that are specific to the implementation of the intervention during active implementation to talk through what's happening with the intervention. You may be talking through data that's being collected along the way. And really also thinking about ways that you can integrate the outside partners in these meetings as well. So in some cases that may look like, if you're working with a university, for instance, that's A, building a partnership with the university, but B, having members from the research team or from the technical assistance team from that university being present at those school-based meetings so that everyone is on the same page and so that help can be given when needed. And then for training and educating stakeholders, again, there were a lot of strategies under that category, but training I have found to be really important when it comes to doing ongoing training, because sometimes when you only train one time during the school year, the person who is trained or the people who are trained, they may leave the school. So it really is important to have ongoing training opportunities throughout the school year, especially if interventions are being delivered at multiple times during the year. And then using train the trainer strategies can help to promote sustainability of interventions by training people who are embedded within the school. Then they can train others within the school. And if a new person comes, they can train them. And so it really helps to build that capacity for training within the school. Then supporting educators is really important. So it's important to support educators by engaging school personnel in various activities or discussions that can increase their motivation or their buy-in to adopt and to use the new practices that are being supported or that are being proposed for the school, and also reducing stress and burnout. So I know that there are some people that are here on this presentation who are focusing on reducing stress and burnout. That is a very, very important area, because especially during this time with COVID-19, with a lot of educators who are completely burned out. My niece is one of them. She's an elementary school teacher, and that's all she talks about usually when I call to check in on her, because she's a teacher in our hometown in South Carolina, and she just talks all the time about how she's overwhelmed. Like, they add more kids to her class sometimes. The school doesn't provide mental health support for teachers, and it's very difficult. You're dealing with students, you're dealing with parents, you're dealing with families. It's a lot. So reducing burnout is extremely important. And so when you are proposing new interventions, make sure that it's not being framed as something that's going to be more of a burden on educators who are already experiencing a lot of burden from their various responsibilities. And so it's really important to figure out ways to promote their well-being, figure out ways to be intentional about involving them and asking them for their input, and then also being sensitive to the fact that they may have a lot of things going on. And so adding an additional role to their plate may be a lot. For some of them, they may be able and willing to take it on. So it's really important to just have those open conversations and to really get their buy-in, because if you don't have that adequate buy-in, that can negatively impact the delivery of the intervention and can negatively impact outcomes for the students. And then it's also important to improve the overall well-being of implementers, like even if they are school mental health personnel, because they are also experiencing burnout during this time. So it's really important to think about all of the different types of implementers, whether they are lay school staff, if they're teachers, if they are coaches, if they are cafeteria workers, if they're school mental health personnel. Everyone needs support during this time. So it's really important to figure out ways to improve overall well-being for the various school stakeholders that are involved in implementation. And then engaging consumers is also important because the students, whether students or their families who are receiving the interventions, it's really important to involve them in that process of selecting the interventions, in the process of implementing interventions, if they can be a part of that, as well as preparing them to be active participants along the way. So it's not just something that you're giving them or telling them to do. They're an active participant in the process. They have a voice. They have a seat at the table to be able to express their concerns, to express their joys, to express whatever it is that they want to express around the implementation, and to really just again foster that team spirit that we're all in this together. And then financial strategies are also helpful. So I mentioned some of those strategies earlier around accessing new funding at either the local, state, federal level, and then also altering or providing incentives for school staff members so that they can enhance their participation within the interventions. And then also, so that may look like things like doing free training or providing consultation or providing grant money or providing gift cards for participation. And all of those things can help to support the implementation of new efforts, especially new efforts when they are delivered in schools. And then changing or altering the infrastructure. So sometimes you, like for instance, if an intervention is being delivered in a classroom, and it may be more beneficial to have the desk in a circle as opposed to the traditional style, whatever it may mean, just taking a look at what could potentially be altered within the classroom or within the school. Sometimes it may look like offering an intervention in a local recreational facility as opposed to in the school itself if there are any issues around space in the school, and really, again, leveraging those partnerships to offer different interventions for students if the school is having issues around space. And then developing local policy support is also really important because, again, having the local school districts on board with offering mental health interventions in the local schools, really assessing the needs of mental health among students within the district, and really working together across different sectors to deliver those interventions, to evaluate them, is very important. And so sometimes it starts with that policy and really making sure that the policy is actually official so that principals know this is something that's prioritized by the district and that this is something that it's okay for me to spend money in the budget to support students' mental health, because overall that's going to support their well-being as well as their academic outcomes. And then lastly, I'm just going to briefly go over this tool that we developed. So I worked with some folks from the Smart Center on this tool. So this is called Adapting Strategies to Promote Implementation, Reach, and Equity. So it's called the Aspire process. And this is something that can be used to explicitly center equity within the adaptation of implementation strategies. So the strategies that I just mentioned on the past couple of slides, those were general implementation strategies that we're saying that, yes, it has an implicit indication that it will promote equity, but it's not explicitly stated. So this is a process that you can use to take a particular strategy and go through this process to really explicitly center equity within the strategy. And so it starts with, as step one, it starts with, actually, so this is the example that I want to go through that I mentioned earlier about promoting adaptability. But step one is all about looking at the assumptions that are underlying the implementation strategy itself. So you have to kind of consider what assumptions are being made and who are those assumptions being made about, and why is the implementation strategy supposed to work? So when we look at this particular implementation strategy of promoting adaptability, it says it's to identify the ways a new practice can be tailored or adapted to best fit with the school or classroom context, meet local needs, and clarify which elements of the new practice must be maintained to preserve fidelity. So when we look at the underlying assumptions of this, by promoting adaptations of the new practice, the core elements can be maintained to preserve fidelity, while other elements of the new practice can be improved to fit better within the school context and meet the needs of the students. So there's that implicit assumption that it's going to be, once we make these adaptations, it's going to be better for the school. It's going to be better for the students receiving it. And it assumes that the adapters fully understand the implementation context and population. And a lot of times, the people who are adapting the interventions may be researchers who may not be working at the school. They may be part of outside organizations that don't really fully understand the implementation context within the school, or they may not really fully understand the population intended to receive the intervention. So then when we look at step two really is to consider the potential sources of disparities that could occur if the implementation strategy is used without explicit attention given to equity. And this step can be informed by various frameworks that outline common determinants, such as the barriers and facilitators that we've been mentioning today, of inequities in determinants of health and mental health. And then it can also, we can also look at the various frameworks that are out there for implementation science that can kind of outline some potential barriers and facilitators that we can really assess during this step, and to see how equity is being framed and how equity could be advanced. And so when we look at the potential sources of disparities within this particular example, adaptation may only include intervention developers or researchers without input from school staff and students who best understand the implementation context. So it's leaving those key stakeholders out of the process of adapting the intervention. And the adapters may lack knowledge regarding culturally appropriate therapeutic processes, knowledge, attitudes, and beliefs. So it's really important to assess what are the sources of disparities that could come up if this implementation strategy is implemented as written, and then figure out how can we then adapt the strategy to ensure that equity is considered in the underlying assumptions, and has the explicit potential to reduce disparities. So we're being very, very clear about how we can adapt the strategy to advance equity. So in this particular example, we would then reframe the strategy to say, using a participatory approach with representation from intervention developers, researchers, implementers, and recipients, identify the ways a new practice can be tailored or adapted to be culturally responsive to different racial and ethnic groups, best fit with the school or classroom context, build on local strengths, and help address local challenges with an emphasis on the priorities of underserved populations, and clarify which elements of the new practice must be maintained to preserve fidelity. So in this case, it of course is a bit longer than the initial strategy, but the main point here is that we have addressed those underlying assumptions, we have addressed the potential disparities that could come up, and we are explicitly centering equity by including more stakeholders that were left out initially, as well as really focusing on the context and the population who will be receiving the intervention. And we're still keeping the part around maintaining those key elements to preserve fidelity of the intervention. So that is all that I have for you all today. I just want to again thank you all for attending the talk today and for listening. I think there may be some questions and answers that we can get into during our discussion. And I always end my presentations with this quote, which is one of my favorite African proverbs of, if you want to go fast, go alone. And if you want to go far, go together. So together, through implementing these different strategies, we can advance mental health equity within schools. And again, I just want to thank you all for your time and attention today. And I will turn it back over to Kelsey and the other Smart Center folks to take it from here. Thank you all.
Thank you, Kim. That was exceptional. There was a lot of very positive and positive chatter full of gratitude. Unfortunately, we don't have time to do the Q&A. And that's okay. I do want to acknowledge that we had some really thoughtful and thought-provoking questions come in, and just thank you all for being so engaged throughout the talk. We will get the questions to Dr. Arnold and add the Q&A resource to session materials. And again, thanks to all attendees and to Dr. Arnold. This was exceptional. Yes, thank you, Dr. Arnold. Also, for those interested in other talks, we have several coming over the next, I think, 3 months. Here is the list of speakers. We have Dr. Boyd coming, Dr. Tish Jennings, and then Tunette Powell and Dr. Gilliam will be joining us. And we look forward to seeing you all at these future talks. Thanks again, everyone.